So this next video is going to be about pericarditis, as you can see, which literally tells you what it is. It is peri, around, cardio, heart, and itis, so inflammation around the heart, meaning in this case that pericardial sac that goes around the heart. If you look at your normal pericardial sac right here, it's just lines the heart. It keeps when the heart is beating. It's providing a little coating, just like the inside your abdominal cavity. You have the fascia, the wrappings, the different layers that are keeping organs from rubbing on each other and that sort of thing. Well, unfortunately, sometimes it doesn't work well when it gets inflamed. Most of the time, by the way, when people get pericarditis, that pericardial sac is getting inflamed by viruses, as you can see over here. It's like 90% of the time. And when that happens, it gets really thick, it gets stiff, it gets crunchy. Okay, so one of the key points about that is when they get that inflamed pericardial sac, then it gets crunchy, and when the heart is trying to beat, then it rubs on the heart. So what they say is that you can hear a friction rub, and I don't know how to make that sound, but it's basically a scraping sound that you can kind of hear every time that heart beats. Okay, so they call it a pericardial friction rub, and you can actually hear that. Okay, so it is what it is. Like I said, most of the time it is viral. Obviously, a heart attack can cause some physical damage and can cause that. AI means autoimmune, not artificial intelligence. And of course, trauma. I'm not sure what kind of trauma you'd have to actually cause a pericarditis, but it'd be pretty significant considering you have your ribs and sternum in front of your heart. But so there's that. I don't know. Maybe somebody had a heart attack and somebody did CPR and caused trauma. Yeah, maybe. Certainly one of the possibilities. Anyway, so as you can see here from the signs and symptoms, you get acute onset chest pain, meaning it's coming on pretty fast. Difficulty breathing, obviously, because again, if the heart cannot contract and expand, it can't go through systole and diastole as well because of that sac being inflamed and literally impeding the progress of the constriction and dilation of the heart. Then that's going to lead to it being much less efficient, and therefore we can end up having some difficulty breathing because of the backflow of blood again. Okay, low-grade fever, as a general rule, by the way, if something's like associated with viruses instead of bacteria, the fevers tend to be more low-grade. Obviously, things like HIV, especially when it turns into AIDS, you don't have low-grade fevers, but as a general rule, stick with that. Okay, that phrenic nerve, go back to your nerves if you need to look that up, but the phrenic nerve can get irritated with this pericardial sac being inflamed and rubbing on that nerve, and that may radiate into your back. So that's another one of those referred pains that we talked about before. Okay, here's my little friction rub. Again, pericardio around the heart effusion. So basically what we're talking about is a little bit of a fluid that is also going to be exuded, more of a response to the friction. Anyway, so you could hear that. Obviously, that's a huge clue if you hear a friction rub, and all of these things should lead you to I can hear it with my stethoscope, this friction rub, and it should kind of bring you back to this clinical scenario on, okay, what could be the problem here? Again, it's probably viruses. It's probably not a whole lot you can do about it anyway, but just to make sure, let's do the EKG. Okay, we've looked at some EKGs in this course already, so we're going to add one on here, and that is your pericardial or pericarditis EKG. So what it says here is your PR segment is depressed, your ST is elevated without Q waves, and if you think about that, we saw another EKG where we had ST elevation, didn't we? So that ST EMI, the STEMI, ST elevated myocardial infarction, was the flat-out subendocardial heart attack. This one, not necessarily causing a heart attack, but you still get some ST elevation. It's just not that high as it was with the STEMI, okay? And we'll see that in a second here. And we'll see the little PR segment depression too. I have some EKGs to look at in a second here, okay? You go down to the treatment, anti-inflammatories. Again, if it's a virus, there's not a lot you can do about it anyway. And if it ends in itis, then, you know, your treatment's going to be anti-inflammatories, of course, because that means it's inflamed. So not really any big surprises there. All right, so here's our EKG on here. Again, this is just a quick EKG review here. This is a normal looking EKG-ish. Where you have your P, Q is right down here, your R wave, S wave, and then T wave over here. And you can see how it broke it up in these little things. Well, what this is saying is you have your depressed PR wave. So all the way from the P to the R here, but you don't have a Q wave. So you're not going to have this little Q wave in here. But this part will be more depressed. Might be a little bit hard to identify on an EKG, that part of it. On the other hand, when you're talking about the ST segment in here being elevated without having your Q wave back here, I guess that's kind of irrelevant almost, but this ST segment being elevated, then that actually looks a little bit different. So if we look at this next slide here, you can kind of see it where you have your, you can pick, again, when you're looking at these EKG strips, just pick some place to start. Okay, and what we're doing here is we're showing you, well, if this first little line over here is your Q wave, how it dips below the baseline, then over here it's not happening. So we just kind of missed our Q wave in this particular segment of the EKG. Okay, then we're going to look at, you know, the rest of it. If you can see this Q, so P, no Q, R, see your S, T here is, it's above the baseline, okay? So right there, your ST segment is elevated, but it's not like the STEMI. Go back and look at those EKGs with the STEMI, and you'll see it met it like halfway down, and it was way the heck up here, okay? This is just, it's an elevation. It's just not a huge elevation, okay? So be prepared for that one also. It's just one more EKG we're adding to our list of things that we should be able to know before getting out of this class. Now, this probably should have been back with my other video when I was talking about infective endocarditis or strep, but it is what it is at this point. Maybe I'll change it for next time, but not going to go back and redo that video. So I'm trying to see if there's anything new on here. Again, we're still talking about that probably group A beta hemolytic streptococcus, although other things can certainly cause infective endocarditis because there's certainly more infections than strep. One thing I do want to emphasize on here is, you know, if you look at the poor dental health part of it, strep tends to hang out in your throat, as you know. And this is one of those things that dentists tend to be a bit on the paranoid side, to be honest, and for good reason, is because if they go ahead and they start cutting around in somebody's mouth and there's a residual strep hanging out, then they could be the cause of that strep getting in the blood and causing, you know, a massive bacteremia, and of course can lead to this heart valve damage that we were already talking about in the other video. So obviously they want to be careful with that. You are probably not going to be, as a physician, probably not going to be doing a lot of catheters on people, but you never know. You never know. Usually it's the nurses, and they're trained severely well on trying to prevent that, and it still happens. Okay, so clearly, you know, IV drug use is, you know, pick an infectious disease, and you can certainly get it from IV drug use, but don't, I guess. Artificial heart valves, just for the simple case, for a simple fact of they're not the natural part of the body, and there's always a risk of rejection with anything. And although they're very good about not getting rejected, sometimes, you know, they're gonna be the focus of some kind of infectious process that happens on the valves too. So again, no big huge surprises here, I don't think. Again, go back to your signs and symptoms that we were talking about before, and go back to that. This doesn't obviously list them all with the infective endocarditis or rheumatic heart disease or rheumatic fever that we were talking about on the other slide. So I'll go check it out. This does have some pretty good pictures of the infective endocarditis, though, as you can see here. the person that wrote this slide, and I actually don't know who did, but they actually call these the vegetations that I was talking about, but they actually went and called them a verrucae, which are warts actually. So I mean, obviously they're not warts, but they kind of look like it, to be honest. Okay, so again, pretty nasty looking dealio. So I'm gonna go ahead and stop this because I do want to talk about cardiomyopathies in a second here. Thanks.